Welcome, children of a lesser joint. I'd like to acknowledge the addition of many new members today and welcome them to our educational group. Today's video marks the beginning of a new educational series, which has no planned end. It establishes a new origination point for the group that will endorse learning from a central focal point of diagnosis. As you can see in front of me, I have a slide. It's a quote by Robert Kennedy back in the 60s when he said, "Some men see things as they are and say, 'Why?' I dream things that never were and say, 'Why not?'" Well, I like that quote because I guess I'm a bit of a dreamer. And I'd like to show you how I dream. Four-sector diagnosis, which has the abbreviation 4SD placed below the temporomandibular joint, fossa, and eminence, is a systematic approach to TMD diagnosis and facial pain. As a matter of fact, I will tell you that it has almost no borders at all. You can use this for almost anything. There is a why in 4SD. And let me tell you what the why is. 4SD is a derivative of a lifetime of my work, dedicated to finding out the root causes of TMD and facial pain disorders. You will see many new things here. You will learn about them. You'll learn how to use them. I'm different from many other people. I acknowledge that. Regardless of what you think and what you may come to think of what I will say, I am not the enemy. The diagnostic approach to 4SD came about as the result of deep belief, conviction, and commitment to learning and discovery that would ultimately provide me with inspirational answers and fueled my passion for academic enrichment and problem solving. The application of 4SD empowers the professional to gather information on a multiplanar level, to synthesize data that they accumulate into a workflow algorithm. It will teach you how to take the information you gather and make them meaningful and purposeful. This particular program is predicated on the molecular basis of disease that incorporates both local and systemic inflammatory disease processes. And when I began to understand what that was about, and I'm never sure that anybody really understands inflammation, it allowed me to fabricate a decision-making tree. It's based on approximately 17,000 articles that I've now accumulated over close to a 10-year period. They're archived in my reference manager. They contain an exceptionally broad range of article contents that allowed me to develop a transdisciplinary approach to the creation of a disease model overlap prototype. The ability to format blood tests so that I could actually look for the diseases that may be causing temporomandibular joint disorders and facial pain. And through that, I was hoping that I might have the ability to improve my diagnoses and help my patients to receive better and more effective care for the management of their specific problems. So let me show you how this works a little bit as an overview and a new starting point. Four-sector diagnosis is based on a quadrant system. I did that on purpose because dentists respond well to a quadrant system. I placed a heart over the area which collects the information related to the patient's symptoms, their past history, what medications they're currently taking, and a family history. The heart that's over here stands for what I believe is the heart and soul of this whole thing. I can actually do many cases without even seeing the patient. In the bottom right-hand corner of this upper left quadrant, which is really the right side, dentists will understand what I'm talking about and giggle maybe, is the cover page of a 19-page questionnaire. There are actually only 17 pages worth of questions, and this continues to evolve. So I can change it, make additions as new information becomes available to me. I add it into this profile system that I have. In the bottom right-hand corner are the imaging studies, the tests that I can order. I also have a place for biopsies, and I squeezed in an anatomical anomaly model to account for certain things that may not be present in the target area from my blood tests. So the way that this works, the way that I gather information, is fairly simple. I try and get all the information in advance. Many patients who come to me have really significant problems. So I will get the imaging studies in advance. That'll be CT scan most of the time, MRI, so I can review it before the patient comes in and begin to formulate certain ideas. At that point, I'm going to project into this area. Now this area over here, which is for the blood studies, are looking for any one of a number of diseases. It can be, just to give you quick examples, it can be the patient that has autoimmune diseases. I can look for immune compromises. I can look for metabolic problems. And I place that on what I call a target area. Now, all this will be validated to a certain degree as to what I expect to see after I do my examination. And let me just introduce you to the young girl in the picture. This is Sarah. Sarah is now my daughter-in-law. We did this several years ago when she was dating my son Eric, and Sarah was nice enough to volunteer to be a guinea pig for me while Eric actually videotaped this whole thing. Now from here, I have now called this my target area. Based on the symptoms, I can create what's called an overlap syndrome model. That's the different diseases I might be looking for based upon what I know about that patient. And then from that, I go directly to the target area. That scores the highest, okay? And I'm going to separate that for you. That target area is where I hope that I'm going to get a disease-based diagnosis. Let me be clear about what I'm saying here. While I've taken into consideration that there may be an anatomical anomaly model, the disease of the joint is predicated on me getting an answer as to why it is failing. That's what I do. If you are a patient, you do not come to see me if you do not want to know the answer to your problem. That's what I do. And so from that target area, I'm able to get a disease-based diagnosis in 92% of my patients. And part of the clarity that I want to provide you with is that this is a heterogeneous group of disorders, that the TMD problem is usually not the primary source of why it has a problem. It's coming from someplace else. And that's what I will teach you about. So when I look at temporomandibular joint disorders, I'm really looking at the oral manifestation, the TM joint problem, as a reflection of systemic processes. That doesn't have to occur. There's an Achilles heel here. And that is, if the problem is only local and does not show up as a systemic problem in the blood, I have to be able to get the answer potentially out of a biopsy, or then go to an anatomic model that may provide me with better answers. Either way, I will rule out certain diseases, and I'll be able to make recommendations to that patient as to how I think they should resolve the problem. And that's key, because I don't have necessarily the same opinions as everybody else, and I doubt very much that you would expect that. What I wanted to be originally, the outcome of this, is that as a result of a disease-based diagnosis, I'd be able to address the total health of the patient. Not that I'm necessarily going to make them very healthy, but in some cases that does exist. I would be able to help them obtain care for medical optimization, which might affect the joint fate, particularly in very early cases. It's also going to give me treatment options based upon what the disease is and what medications or procedures may be available. It gives me a wider array of choices. The thing that I wanted most to come out of this is, based on the disease-based diagnosis, to accumulate data as to what diseases patients had when they presented with temporomandibular joint disorders, and see how the treatment options that were suggested and approved compared with the outcomes of those patients who had certain diseases, because nobody's ever done that. Of course, you realize at this point what's actually occurred here. I've actually taken away the occlusomuscular originating point of what we think is temporomandibular joint disorders. What I have preserved here is the fidelity of the relationship that the temporomandibular joint disorder and inflammatory changes that occur within the joint and the structural damage that comes as a result of inflammatory processes, regardless of their cause, causes the occlusal disturbance. And through that, some of us are able to obtain effective care by manipulating the joint into different positions, because what we're doing is we're modifying the load locus where a joint might be sitting on inflamed tissue. If we move them off that a little bit, sometimes we can be able to resolve some of the pain and improve the function. However, I want you to be able to separate the two things that I'm talking about here, because to a large degree, at least in my mind, they're in conflict with one another. The patient is coming to us for a specific reason. They want us to take away the pain, improve the function, and make the quality of their life better. In some cases, we provide symptomatic care. We're able to make those improvements without recognizing that there is a disease-based diagnosis that needs to be made. And in manipulating the joint into different positions that may actually affect some improvement, what we've done is given that patient a false sense of security, because a lot of the diseases that I'm going to be talking about are relapsing and remitting. So the patient can actually go into a quiescent cycle, go into a stage of remission, and have the false sense that they in fact may have been treated successfully without ever realizing that this thing is going to come back. And it may not come back for many, many years. You take a look at the historical history of a disease like rheumatoid arthritis or lupus. It can disappear for years, as many as 30 to 50 years, and then all of a sudden, in their old age, if you're still practicing, you find that the patient's disease comes back almost out of nowhere with a vengeance. Now, it may very well be that they don't need any additional treatment options after you've resolved that, but there are some very serious disorders that are occurring here, and virtually none of you are aware that they even exist. If I am looking for diseases, I'm going to give you one of the mother themes that exists here. On the top left, actually the middle left over here, is Louis Pasteur. That's his picture. And he said that all diseases are caused by microbes. Almost every single disease I look at has a candidate organism or multiple organisms. His contemporary and adversary was Claude Bernard. He said the microbe is nothing. The terrain is everything. What he was describing was what issues are underlying in us that allows the susceptibility to occur. And if you want to hear about susceptibility, you can go to my first lecture in the video files on the human histocompatibility complex called HLA, human leukocyte antigens. So when you take a look at why diseases occur in certain people, we can incorporate many factors into this, which are on a genetic level, how changes occur during the course of our lifetime, in real time, on an epigenetic basis, and this determines what the disease expression is going to be. Then, of course, there are very more challenging questions, which, why now? Why does it occur in that particular location? And so here I've provided you with an overview of what the diagnostic series is going to be about. And I will show you how I put all these elements together, and I am able to use information to go back to this slide as a trafficking device where all of these sectors serve as feeders to fuel the target area and help me get better results. So, as an ending to today's lecture, for those of you who are new to the group, I always say at the end of my lectures, please join me for the next video where I'll be rocking it out with Jaw Talk.